Hello and welcome to the topic Osteoarthritis in the Rheumatology module. By the end of this topic, you should be able to define osteoarthritis, discuss the pathophysiology of osteoarthritis, describe the radiographic characteristic findings seen in osteoarthritis, differentiate osteoarthritis to other types of arthritis, and discuss the principles of management. Let's get started. So what is osteoarthritis? Osteo refers to bone, arth meaning joint cartilage, and itis simply means inflammation. So osteoarthritis refers to the disease involving inflammation of the bone in joint cartilage. It occurs when the protective cartilage that cushions the ends of your bones wears down over time. Although osteoarthritis can damage any joint, the disorder most commonly affects joints in the hands, knees, hips, and spine. A joint is a point where two or more bones meet, and each bone glide over each other through an articular cartilage. The synovium, which forms the inner lining of the joint. The synovium composes of loose connective tissues, blood vessels, lymphatic vessels, and surface type A cells that clear cellular debris, and type B cells that produce the components of the synovium fluid, which helps lubricate the two articular surfaces. Pathogenesis involves the localized loss of cartilage with remodeling of adjacent bone. This adds a significant amount of friction between the two bones, which then leads to inflammation and pain at the joint area. Cartilage continues to erode away until the bones are exposed, increasing friction. Osteophytes start forming over the sides of the bone. There's a few risk factors you may want to consider for this condition. They are age. Cartilage often degrades over a long period of time. Next is inflammation, and it is found that interleukins such as IL-1 and 6 and tumor necrosis factor play some role in the inflammation that leads to osteoarthritis. This increases catabolism, which further breaks down the cartilage. Obesity is one of the commonest causes for the early appearance of osteoarthritis, and osteoarthritis may be secondary to hemochromatosis. Osteoarthritis characteristically affects the distal interphalangeal and the nodes, and they are called Heberdin's nodes. As for the proximal interphalangeal joints, it's called Bouchard's nodes. The first metacarpophalangeal joint and the carpometacarpal joint are also classically involved. Joint swelling is bony in nature, unlike the boggy swelling which occurs in inflammatory arthritis. Thinner wasting occurs in osteoarthritis of the first CMC or carpometacarpal joint due to disuse. The pain is exacerbated by exercise and relieved by rest. Although in advanced disease, rest and night pain can also develop. Usually the joint don't swell. Stiffness is a pain occurrence which happens in the morning lasting less than an hour, but it comes back at the end of the day. Now these are the typical X-ray changes of osteoarthritis. There would be decreased joint space, subchondral cyst present, as well as osteophytes forming at the joint margins. The NICE guidelines published on the management of osteoarthritis in 2014 suggest that all patients should be offered help or assistance with weight loss, given advice about local muscle strengthening exercises and general aerobic fitness. Transcutaneously, an electrical nerve stimulation and shock absorbing insoles or shoes can be recommended. If conservative methods fail, then one would need to be referred for consideration of joint replacement. Pharmacological agents which help with reducing pain and inflammation include paracetamol and topical NSAIDs, which are first-line analgesics. Topical NSAIDs are indicated only for osteoarthritis of the knee or hand. Second-line treatment is oral NSAIDs or COX-2 inhibitors, opioids, capsaicin cream, and intra-articular corticosteroids. A proton pump inhibitor should be co-prescribed with NSAIDs and COX-2 inhibitors. These drugs should be avoided if the patient takes aspirin. Before we end, let's get on with a quick revision on the differences between osteoarthritis and rheumatoid arthritis. Osteoarthritis involves the distal interphalangeal joint and proximal interphalangeal joint, rarely affecting the metacarpophalangeal joint. Rheumatoid factor and anti-CCP antibodies are absent. Joint fluid leukocyte is less than 2,000 cells. As for rheumatoid arthritis, the morning stiffness typically lasts more than an hour, and you would expect to see joint fluid containing 5,000 to 50,000 leukocytes per millimeter cube. Let's summarize. Osteoarthritis is the inflammation of the bone at the joint cartilage, which leads to loss of cartilage over the joint space area and formation of osteophytes. Typically, this affects small joints of the hands and knees. Areas affected are usually stiff, tender, and has a bony swelling. There are characteristic radiographic findings which include subchondral cyst formation, loss of joint space, and osteophyte formation. Treatment is by medications to reduce pain and inflammation. Non-pharmacological approach with weight-bearing exercises, weight loss, and aerobic exercises can help alleviate pain and burden of the disease. We have come to the end of this topic. Thank you.